Hi everyone, this is going to be part 2 of my top 11 rashes video. In part 1 we went through 6 out of the 11, and now that I've started recording this second video, I realized that the 6 rashes that I talked about in part 1 are really on the lower end of the spectrum of seriousness. They are quite serious for any parent or child to be going through, but compared to the rashes that we're going to be talking about today, they are quite simple in terms of their healing and their treatment, in that they do resolve in quite a short period of time, and the actual effects on the body are quite less pronounced in terms of long-term complications compared to the rashes that we're going to talk about today. So here are now what are going to be number 7 to number 11 of the top 11 rashes. So the first rash that we're going to be talking about today is meningococcal meningitis. Now, this is a condition that I've talked about in one of my previous videos. So this is sort of going to be a summary or a shortened version of what that video was talking about. But meningococcal meningitis is a very, very serious condition, and the name should tell you that straight away. Meningitis is an inflammatory condition of the meninges. The meninges of the brain are the central nervous system are essentially the protective layers of the brain, which prevent any trauma and essentially allow it to be away from any pathogenic organisms. But if there's inflammation on the brain, then that can put a lot of stress, both mechanical and chemical, on the brain, which can cause it to become increasingly damaged, which can lead to quite serious complications. Now, the causative agent, as I went through in the other video of meningococcal meningitis, is the Neisseria meningitidis bacterium. The interesting thing to note about this bacterium is that it only infects humans. So humans are the only reservoirs, or I should say the only organism that are actually impacted by this bacterium. So transmission of this condition is quite common to what we see with other conditions, in that it's transmitted through coughing, sneezing, or any, I should say, throat secretions. And that should make sense, because if you've watched my video on the meningitis infection, you'll remember that firstly, the bacterium starts off in the throat, in the upper respiratory tract, allows that part of the tract to become more permeable to the bacterium, and from there it moves into the bloodstream and then to the brain. So that kind of makes sense as to why this bacterium spreads through that particular mechanism. Now, as I mentioned before, this condition causes for the inflammation of the meninges of the brain. So all of these symptoms are related to the brain and systemic complications. So firstly, a symptom of this condition is a stiff neck. And that makes sense, because the meninges of the brain also extend through the brain, midbrain, the neck, and into the spinal cord. So if these structures become inflamed, it's obviously going to affect the ability of the neck to turn. So it's going to be causing a stiff neck for the person who is impacted. Other effects include a high fever. So as opposed to the conditions that we saw in the part 1 of this series, which are usually causing low-grade fevers, this causes a high-grade fever. Sensitivity to light can also occur. So now we're seeing that this condition can actually cause neurological effects as well. Confusion can also occur, because this bacteria can interact with various structures of the brain. Headaches can occur, and that's quite self-explanatory, and that can occur with other conditions as well. And vomiting as well, because essentially the part of the brain which is associated with the vomiting reflex is not protected by the blood-brain barrier. And that's for good use, because the brain should know if there's any poisons or any other substance that is damaging to the body present within the blood. And that ensures that if there is something present, then, well, the vomiting reflex is activated to try and get rid of it. And in that case, since the Neisseria meningitidis bacteria becomes exposed to that vomiting center, the brain, or the body, I should say, will try and get rid of it. Now, since this is such a serious condition, and I should say the silver lining to this condition is that it is a bacterial condition, we can easily treat it with antibiotics. So the treatment is with, in fact, immediate antibiotics. So this is an emergency scenario. What I also mentioned in the other video talking about the meningitis infection is that a lack of treatment is invariably, and I mean invariably, fatal. So if a person with meningitis is not treated, then they will always die. So another way of diagnosing meningitis or meningococcal meningitis is by doing a CSF aspiration. And this can be done by doing a lumbar puncture, which is when we take cerebrospinal fluid from the lumbar spine, or basically the spinal canal. And the key features that we will see from a CSF aspiration is that we will see leukopenia, so a lower or a low leukocyte count, because these leukocytes are busy fighting the infection in other parts of the body. And we will also see hypoglycemia, or a low glucose count within this CSF. And well, why is that the case? Well, essentially, the CSF normally contains a certain amount of glucose because the brain, let me rephrase that. The brain and spinal cord requires glucose for its function. But in the case of bacteria, these bacteria can actually consume that glucose for their own means. So if that glucose has been consumed by the bacteria present within the cerebrospinal fluid, there is going to be lower levels of glucose present within the fluid, and that makes sense. So in review, meningococcal meningitis is caused by the Neisseria meningitidis bacterium, and it only infects humans. It's spread by coughing, sneezing, and throat secretions because it starts off as an upper respiratory infection. Symptoms include stiff neck, high fever, sensitivity to light, confusion, headaches, and vomiting. And treatment is immediate antibiotics with CSF aspirations showing leukopenia and low glucose. The key thing to remember with this condition is that although it is very, very serious, it is completely preventable by a vaccine, and that is why many government programs around the world allow for the inclusion of strains A, C, W, and Y of meningococcal bacteria. The B strain is quite new and therefore is not, I should say, at this point in time, subsidized by the government, but it can be purchased. The next condition that I want to talk about is called Staphylococcus scalded skin syndrome, abbreviated to SSSS. And like many of the other conditions that I've talked about in this video, it is quite self-explanatory in its naming. So it's called Staphylococcus scalded skin syndrome. So let's break down this word firstly. So Staphylococcus refers to a particular type of bacteria, and it refers to the Staphylococcus bacteria. So we already know the causative agent. Scalded skin syndrome refers to something that's related to the skin, and scalded actually means something that is burnt. So in this condition, we see that the skin appears burnt. So if we put all of that information that we've talked about so far, Staphylococcus scalded skin syndrome essentially is a condition that is caused by the Staphylococcus bacterium, and that causes for a rash on the skin to be present, which causes for the skin to look like it's burnt. So let's look at that in more detail. So Staphylococcus scalded skin syndrome is an illness characterized by a red and blistering rash that looks like a burn or scald. And the reason why we say that it looks like a burn or scald is that it contains many vesicles. And if you've seen my video on the morphology of different rashes, you'll note that vesicles are fluid-filled eminences that are present on the surface of the skin. And in addition to vesicles, we also see what are called bullous lesions. So bullae, which is once again another rash morphology that I went through in that video, are fluid-filled but larger than vesicles. So essentially, what happens in this condition is that in addition to the skin appearing burnt or scalded, what we actually have here is that there is a separation of skin cells from the underlying dermis. Now, how does that occur? Well, essentially, the skin cells become unstuck by the pathogen breaking up the desmosomes that hold the skin essentially together. So the Staphylococcus bacterium affects or attacks. So Staphylococcus attacks the desmosomes. And if you know about the various intercellular proteins that are present, you'll know that desmosomes are responsible for attaching cells to one another. If these desmosomes have been damaged, then cells aren't able to attach to one another, which means that by attacking these desmosomes, cells come apart. So what we see with this particular condition is we see what's called a positive Henochschonlein sign. Now, what's a positive Henochschonlein sign? Well, essentially, to test for if we suspect a patient has Staphylococcus scalded skin syndrome, what we can do is that we can run our finger over the surface of their skin. And if you try it on yourself right now, if you run your surface, if you run your index finger over the dorsal surface of your hand with some force, you'll see that the skin stays in contact because it's intact. But what happens with Staphylococcus skin syndrome is that even with minimal force, by stroking the skin, we can see that blisters start to form. And that's due to the desmosomes being unable to be essentially glued or allow for cells to be glued to one another. And since these desmosomes are unable to structurally allow for force, they essentially mean that the skin comes apart very easily. So cells come apart, which causes for what we call a positive Henochschonlein sign, which is when we rub the skin and the skin comes apart. So this is essentially due to the epidermis coming apart. Symptoms of Staphylococcus scalded skin syndrome include a widespread rash, and this rash, as I mentioned before, contains bullae. An important thing to also note with Staphylococcus scalded skin syndrome is that in newborns, the entirety of the newborn skin can be affected. And when this actually occurs, this condition actually takes on a different name. When the entirety of newborn skin is affected, it's actually now called Ritter's syndrome or Ritter's disease. That's a shame. Alright, so a quick review of Staphylococcus aureus skin syndrome. It's caused by Staphylococcus bacteria, which causes for a red and blistering rash, which can resemble a burn or scald due to the presence of vesicles and bullous lesions. The Staphylococcus bacteria specifically affects desmosomes, which hold cells together, and causes for these cells to come apart, causing for a positive Nikolsky sign, which is when we rub the patient's skin, and with minimal effort we cause for blisters to form, which can be very painful. And the rash is quite widespread with bullae present, and if in a newborn the entirety of that newborn's skin is affected, a new condition called Ritter's disease is what results. Now, this next condition that I'm going to talk about is, in my opinion, probably one of the scariest conditions that I've seen. And if you do want to search up this condition on Google Images, I do warn you, it is a condition that causes a skin rash, but the rash is quite nightmarish in its presentation, especially clinically. And this condition is called toxic epidermal necrolysis. And yes, its clinical presentation is as scary as its name. It's usually abbreviated to just TEN, T-E-N, toxic epidermal necrolysis. And in its presentation, it's actually a quite rare, acute, and potentially fatal skin reaction. So rare, acute, potentially fatal. And the reason why it's fatal is because, like Staphylococcus aureus skin syndrome, it causes for the loss of skin, but the loss of skin in toxic epidermal necrolysis is very generalized and large areas of the skin are lost. So what we essentially see is that entire sheets of skin of the person come off. So sheet-like, I should say, skin loss, as well as mucosal loss, which is also sheet-like. So the thing with toxic epidermal necrolysis is that it's not usually, or it's very rarely caused by an actual pathogen, such as a bacteria or a virus. It's actually caused by an allergic reaction. And this allergic reaction can be due to medications. It can also be caused by autoimmune diseases. So medications, allergic reaction, autoimmune diseases, other allergic reactions such as to food. So I'll just write allergic reactions in general. And symptoms can include the presence of conjunctivitis, in addition to the sheet-like loss of skin. So conjunctivitis, oops, I spelled that wrong, just one second. So conjunctivitis, red and crusted lips, because the lips are a part of the mucosa, and therefore they also lose their tone. Irritation of the pharynx, once again a part of the mucosa. And also irritation of the esophagus. Esophagus, I think US? Wait, one second. How do you spell esophagus? E-O-E-S-O, esophagus, let's say. Sorry if it's wrong. Also can cause urinary retention, because if there is a destruction of the urinary epithelium, then we can cause for urinary retention and possibly an obstruction as well. Coughing, respiratory distress, fever, and diarrhea, because once again, the gastrointestinal tract contains epithelial tissue, so this tissue is going to be affected as well. Now, as I mentioned before, this is a very serious condition, and the mortality of toxic epidermal necrolysis is actually 30 to 35%. So as you can see, this is a very, very serious condition. And to quickly review it, it's a rare, acute, and potentially fatal condition which causes sheet-like skin loss and mucosa loss. Medications and allergic reactions due to these medications can cause it, as well as autoimmune diseases. And as you can see, the list of symptoms is quite extensive, and mortality is between 30 and 35%. Now, before I move on to the next condition, I just quickly want to talk about a quick nomenclature rule when we talk about toxic epidermal necrolysis. Toxic epidermal necrolysis can actually be called two different conditions depending on how much of the body has been affected. So if less than 10% of the skin of the body has been affected by this condition, then we call it Stevens-Johnson syndrome. All right? So Stevens-Johnson syndrome occurs when less than 10% of the skin has been affected by this condition. When 10% to 30% of the skin has been affected by this condition, it's essentially a mix between Stevens-Johnson syndrome and toxic epidermal necrolysis. So we essentially called it a mixed syndrome, and that mix, which I'll abbreviate, is called SJS, so Stevens-Johnson syndrome, toxic epidermal necrolysis. And finally, if more than 30% has been affected, then we call it toxic epidermal necrolysis. So this is just a small thing, but when you're categorizing a condition, if a patient does have this condition, then it's important to denote how much of their body has actually been affected. Alright, so the next condition that I want to talk about is called toxic shock syndrome. Now, toxic shock syndrome can sometimes present as a rash, but the interesting thing to note about this condition is it usually causes systemic complications. So it can be caused by various types of bacteria. The common types include Staphylococcus aureus, so Staphylococcus aureus, and Streptococcus pyogenes. And an important thing to note about this condition is that toxic shock syndrome usually, or I should say actually more commonly presents in menstruating women. And it's important to note that menstruating women are present with this condition to a greater extent than other populations, because in environments where there are not appropriate menstruating facilities available, or if the woman herself does not have proper menstruating practices, then say for example if a tampon or a pad is left in contact with the vagina for an extended period of time, that creates a perfect environment for bacteria to proliferate in, because a pad or a tampon essentially closes off the vaginal tract to the external environment, and by closing it off, it creates a very moist and warm environment, and bacteria love those kinds of environments. So if a pad or tampon is left in that environment for an extended period of time, then bacteria can grow, and if these bacteria grow to an enough extent, they can cause toxic shock syndrome. So symptoms, since this is such a systemic condition, toxic shock syndrome can result in a fever, vomiting, diarrhea, skin rashes, which is the very theme of this video, muscular aches, sore throat, the presence of red eyes, confusion, hypotension, joint pain, photosensitivity, and kidney failure. Now you may be wondering, well, why did I list so many symptoms of this condition? This is just to illustrate to you as to such a great extent to which this condition actually affects the body. As you can see, fever is generalized, vomiting, diarrhea related to the gastrointestinal system, skin is related to the integumentary system, muscular aches are related to the musculoskeletal system, sore throat, let's say, also is associated with the integumentary system, eyes, confusion are both related to neurological conditions. Hypotension is the cardiovascular system. Joint pain, once again, the musculoskeletal system. Photosensitivity, once again, a neurological condition. And kidney failure is part of the renal system. So as you can see, toxic shock syndrome is not simply a rash or anything like that. It's something that affects the body as a whole. And therefore, it's something that should be taken very seriously and treated very seriously. And essentially, if we're talking about menstruating women, we should be educating women maybe who don't have the appropriate resources or are not aware of proper menstruating practices about the dangers of this condition, and encouraging them to ensure that their menstruating practices are hygienic and sterile. So in review, toxic shock syndrome is caused, or more commonly, by Staphylococcus aureus and Streptococcus pyogenes bacteria. It's usually seen in menstruating women, and as you can see, its symptoms are very, very broad. Alright guys, so this is the last condition that we're going to talk about in this series of rashes, my top 11 rashes number 11. This condition is called Henochschonlein purpura, or quite funnily abbreviated to HSP. So Henochschonlein purpura, the first part of the disease name is not very helpful because it's just the name of the people who essentially discovered or named the disease, and that is why these days we're moving away from naming diseases from people and rather resorting to the actual physiological condition that is occurring. But purpura does give us a bit of an indication of what this condition may actually be. Purpura relates to the presence of breakage of blood vessels under the surface of the skin, and this breakage is usually due to bacteria or some sort of extravasation occurring or coagulation. So this is probably going to be a very serious condition. And once again, Henochschonlein purpura is a very, or I should say is more common in childhood, and in fact it is the most common cause of vasculitis, which is, as the name suggests, itis of the vascules or inflammation of the blood vessels in childhood. So the most common cause of vasculitis in childhood. Now, the thing with this condition is that the rash presents with what we call palpable purpura, which means that a purpuric rash is present, which is pretty self-explanatory, but the rash itself is feelable or palpable. You can actually feel it. Palpable purpura. In addition to this palpable purpura, other symptoms can include a fever and arthritis as well. So a common clinical presentation of Henochschonlein purpura is the presence of not only juvenile vasculitis, but arthralgia and arthritis as well. The main investigations that you do to identify this condition, in addition to clinical analysis, is performing a urinalysis. And the reason why we do this is that there are key indicators in the blood that are present, and usually instead of doing an invasive technique such as a blood test on a child, it's usually preferred that we perform a urinalysis because urinalyses are not invasive and comparatively they may be less traumatic for the child to do. And furthermore, they do give us a good indication and they're quite cheap as well to perform. So in terms of management, once again, this is a condition that is usually treated by supportive treatment. So management includes controlling inflammation using NSAIDs, so non-steroidal anti-inflammatory drugs for mild pain. And if the patient does suffer from severe or moderate pain from this condition, then we can also use steroids. Now, the main triggering event that causes for the vasculitis, arthralgia, fever is, like many different conditions, an upper respiratory tract infection. So the triggering event for Henochschonlein purpura, which is the actual purpuric rash and other conditions, is an upper respiratory tract infection. Another condition, another cause that is present but less so, is a drug exposure. So if a person or if a child is allergic to a drug or is exposed to that drug and has a negative reaction, that can also cause Henochschonlein purpura. And just a quick note on the actual aspect that causes for the vasculitis in childhood. The reason why we do get vasculitis is that immune complexes get stuck in small vessels. So essentially, if this can be characterized or likened to an autoimmune condition or an allergic reaction, the antibodies stick to the antigen, but there is no adequate immune response occurring, which means that these antigen-antibody complexes or immune complexes get stuck in smaller vessels and cause for inflammation of these vessels, because initially there's a reduction in blood flow, and so the vessel tries to accommodate for that by inflaming its size, by increasing or vasodilating, but obviously this is not adequate, and that causes for inflammation, negative inflammation for the person. So in review, Henochschonlein purpura is a common or more common condition in childhood. It's the most common cause of vasculitis in the childhood, and it's this vasculitis is caused by immune complexes getting stuck in small vessels. The main manner in which we sense this condition is through a urinalysis, and treatment is through NSAIDs and steroids. And the main triggering event for this condition to occur is an upper respiratory tract infection or drug exposure. So, thank you very much for watching part 2 and the final part of this series of my top 11 rashes or conditions that cause rashes. I hope you've understood that the conditions that we've gone through in this video in particular have been more serious than the conditions that we went through in the last video. But at the saying that, both of those videos can cause, or the rashes explored in both videos can cause for quite serious complications. So that is to keep in mind. Thank you very much. This was once again a very long video. I'm looking here, it's going more than 35 minutes now. But thank you very much for watching and sticking with me, and I hope you enjoyed the video and I hope it all made sense. Thanks.